Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
Good afternoon, THOR listeners. My name is Andre Kapp. I'm a member of the THOR Executive Committee, and I'm speaking to you today from the Solstrand Resort in Norway, where we are finishing up the THOR 2025 annual meeting. Today, we'll be speaking with Dr. Jennifer Gureney, Colonel, U.S. Army. She is a trauma surgeon and burn surgeon and director of the Joint Trauma System in the United States. Jen, it's great to have you here today. Let's remind our listeners a little bit about how burns have been resuscitated, how burn patients are resuscitated, why they need resuscitation in the first place, and then we're going to get into a little bit about how the field might be evolving, because I think there are some interesting things happening
for sure
that we can talk about. So let's start with the basics.
Okay, so we'll start with why burn injuries need to get resuscitated. So thermal injury causes a massive response, physiologic response, inflammatory response, and burn shock is very real. So they need, and they have this intravascular leak, and so they need to get resuscitated. They need to, because they'll go into a state, especially large burns, not necessarily small burns, but large burns will have shock. And so, you know, the way that burns are resuscitated mostly, not everywhere, is with crystalloid. Mm-hmm. And, you know, I've always said in surgery, if there's like 8 different ways to do an operation, it's probably because not one of them is the best. And there are like multiple different ways, multiple different formulas, the Brook formula, the modified Brook formula, the Parkland formula, the Evans formula, lots of different formulas to resuscitate burn patients. But pretty much it's based on the total body surface area, and then how many cc's per kilogram, and that's divided over time with the first part given in 8 hours, and then the second part given in over 16 hours, so the first 24 hours of resuscitation. But what we really want to talk about, I think it's so important, is a history of burn resuscitation, because thermal injury is old. It's been, and if you want to learn something new, go back to the future. And like we've seen with whole blood resuscitation, very similar stuff with burns. Burns used to be resuscitated with plasma. And I know you know this, and I hope most people that are listening to this know this. And then we evolved to crystalloid. Lots of reasons that plasma fell out of favor after World War II. And plasma was pooled, and we didn't have infectious disease testing, and there was a lot of hepatitis, so it fell out of favor. But even when plasma became safer, we never went back to it. We're starting to go back to it now, going back to the future, just like we've done with whole blood resuscitation. But, one of the things we focus on a lot at THOR is, far forward remote resuscitation, remote damage control resuscitation, military readiness, military preparedness. Another interesting historical thing about burns is that prior to World War II, there was a huge investment in burn research, from chemotherapeutics to resuscitation, which really paid off in June of 1944. When was Pearl Harbor?
December 1941.
Okay, December 19. Thank you. I got December right.
I got thinking December. Of D-Day.
I was thinking of D-Day. I was thinking of D-Day. You're right.
Yeah.
Yes, December of 1944. Thank God this is Andre Kapp, because you are an encyclopedia. But you're right. But it paid off in December 1941, Pearl Harbor, because resuscitation with plasma and what was called the Beecher formula paid off. We talk also a lot in military preparedness about the military-civilian reciprocity, and how during times of conflict the civilians learn from the military, because we're seeing so many combat casualties, and during interwar periods we learn from the civilians, and we have to have that continued learning healthcare system of military-civilian like trauma systems. But then go a few years later to massive, still the largest fire in U.S. history, Coconut Grove fire, in the 1940s in Boston, and the patients were going to Mass General Hospital and also being resuscitated with the Beecher formula, which was kind of used during World War II. So plasma was a standard resuscitation for burn shock, which makes sense because burn shock is written about as a plasma deficit. What's also interesting about history is in the 1970s, when component therapy was being discovered, there was a bunch of research on dogs. We switched to crystalloid for resuscitation of trauma patients because we were resuscitating the interstitial space. There's papers written by prominent scientists and burn surgeons that say, burn shock is a plasma deficit. So therefore, resuscitate the interstitial space with crystalloid. And I read that over and over again. I'm like, I don't understand that.
Right.
So there's essentially two ways that the body can that you can have plasma. One is you can give plasma. And then the other way is with the liver makes plasma from water or fluids that are absorbed from your intestine, go first pass through the liver, and the liver makes plasma. So you can either increase your plasma with enteral resuscitation, which I am a fan of too, and I think we need to be really thinking about that. It's probably better for patients. And then plasma. Plasma should be used for burns. And there's still, I know it's like I'm going way too long on this one question, but there's still a lot we need to learn about plasma because like we heard in I think it was Matt Martin's lecture yesterday, the two different endotypes and the way that people respond differently to plasma. Precision medicine, plasma resuscitation, understanding inflammation better. But anybody that's taken care of a really sick burn patient and sees how, pro-inflammatory they are and how volatile their hemodynamics and their physiology is, I think recognizes that we need to continue to drive change with burn resuscitation to make it better.
Let me frame this a little bit for our audience here. So if you resuscitate, let's say somebody with let's say 100 kilo person, just keep the math easy, who's got like 40% TBSA. Okay, so a bad burn, right? How much fluid is this person going to
make
get?
Me do public math. I mean, it's not that hard, but
okay, but forget about actual numbers. Just ballpark, like over the course of the first couple days of resuscitation, this patient is getting tens of liters of fluid.
Yeah,
They literally swell, right?
They swell.
The nurses or the burn unit will say you got to swell to get well.
Yeah, which we should question that dogma for sure.
We should question the dogma, right?
Yeah.
But if you use, so you mentioned the Beecher formula. That, as I recall, was sort of a mix of plasma and
normal saline.
Right? 1-to-1 maybe?
75 cc's, yes. They would mix it 75 cc's and 75 cc's. That's what it says in his literature from the 1940s. Right. But yeah, it was 1-to-1. It was 1-to-1 of plasma and normal saline.
And they would give that with a target of basically, I can't remember, it was normalizing the hematocrit or protein content of blood?
Yeah, well, I don't know if they were looking at the protein content, but when you have burn shock, in addition to having changes in your hemodynamics, you get very hemoconcentrated, so the hematocrit goes up.
Basically, the plasma leaks out.
Yeah, the plasma leaks out, so hematocrit goes up since it's a percentage. Other things with burn shock, urine output goes down, lactate goes up. So any formula for resuscitation. So how Beecher did it and what their goals for endpoints for resuscitation, I'm not totally sure, to be honest. Like I don't know.
It was reduce the hemoconcentration, right?
Yeah.
The point here is that they gave way less fluid.
They gave way less fluid.
Right. And so you're not then diuresing this patient over the course of the next 2 weeks to get rid of all that
which is what we do
edema,
now, right? We give massive amounts of fluid. So you mentioned, let's say 80 kilogram person, 40% burn. So it's TBSA times, whether you're using the Parkland or Brook or modified Brook, either 2 or 4 cc's per kilogram per TBSA. So it is liters. It's 8, 10, 12. And here's the thing. Kevin Chung, I'm sure you read Kevin Chung's paper, Fluid Begets Fluid. What happens is we just get into this cycle of giving more and more fluid. So yeah, in like 48 hours, they could get 16 to 18 to 20 liters of crystalloid, and they continue to get swollen. They have issues with, oxygenation and ventilation. The edema in the wounds makes a difference in how they respond to excision and grafting. One of the biggest changes, because when you go back and look at outcomes, okay, so you brought up, what the endpoints of resuscitation were in the 1940s when they were using plasma and the Beecher formula. Outcomes for burns weren't great because in the 1940s, the risk of infection was so high because it wasn't until 1970, I think 71 or 72, that Dora Janowitz wrote a paper about early excision and grafting. And so that really changed burn mortality as well. And that was rapidly adopted. And everybody recognizes the faster you get the burn off, because a burn is so pro-inflammatory and the risk of infection over time, the faster you get the burn off, the better. So that's also the balance.
Dead tissue's got to go.
Dead tissue's got to go. And I think people would agree, but it's not like so when we talk, I learned so much from being at the U.S. Army Surgical Research Burn Center, and I learned a ton from the nurses. The nurses knew when a patient would convert their burn wounds. And this was one thing that was always confusing to me. So burn patient comes into the trauma bay, they get their initial resuscitation, and they go up to the burn unit. And they're getting their crystalloid resuscitation, 600 cc's an hour. Now remember, the initial fluid resuscitation is your starting point, and then you adjust it depending on their urine output and if they're hemodiluting and what their lactate's doing. And the burn nurses would say, and you'd see these wounds that would look like, it's like, oh, this is going to totally heal. The wounds would be blanched, they'd be moist, they'd be slippery, like they were definitely partial thickness burn wounds. They were not dead tissue, blanching tissue. And the nurses would say, these are going to convert. And I'd say, why? Like what?
Convert to?
To convert to full thickness, right, and need to be grafted. And if you have a person that's 60% like partial thickness burn wounds and you're going to be doing all that grafting, it's a bloodletting, it's a lot of, and the nurses were right. And what I've always questioned is how much of this are we doing? Because we're giving them so much fluid and that interstitial edema happens and those little blood vessels, those little those end capillaries that have to travel through the, edematous dermis to get to the burn wound. Like, does that make a difference? And then not to mention some of the topicals that we use, like they're great for killing Pseudomonas, but they're not so good for fibroblasts and, inflammatory cells that you need, neutrophils, fibroblasts to heal a burn wound. So I think one of the most important things, and THOR does this so well, right, is question dogma.
Right.
Like we need to question, we should be looking at everything that we're doing when we're taking care of patients and saying, are we doing our best? And, look at all the things that have changed. Like, so, ABCs are now CBA. Mm-hmm. That's a huge dogma change, right? We're doing circulation before airway. We've recognized the importance of that. Just so many things we do in the care of the critically ill or wounded patient, and thermal injury goes under wounded, or injured, sometimes makes them sicker. And I think that resuscitating with large amounts of crystalloid makes them sicker. A lot of the things that we see are probably a crystalloid lesion, giving liters of crystalloid, not to mention the way we feed people. That's a whole other conversation, which you don't want me to get into. You've heard my spiel on that before.
But. So Jen, I totally agree with you. The question, I guess, Beecher probably had some well-informed insights, we'll say, into how to take care of patients, but he didn't do a randomized trial.
No.
And then we switched to these various formulas that you mentioned, Parkland Brook, Modified Brook, et cetera. None of those were really developed in the context of a randomized trial either, or validated in a trial. And so we think there's a problem here. It can't be good for you to double in volume with all of this fluid that you're putting in, right?
And then spend the next 4 weeks fighting every consequence of all the massive, crystalloid resuscitation that we've done.
And you saw this in trauma, right?
Yeah, and also, who did the trial saying that we should be using crystalloid over plasma? Or who did the trial that said we should be using clear fluids over, component therapy or or whole blood? It's so funny how we're so hamstrung by the regulatory process now, and regulatory science is not keeping up with science. It's not keeping up with all the changes that we're seeing. And so, as you know very well, we've been pushing for a long time to get dried plasma FDA approved to be widely used, because we used to use it almost 100 years ago. The world is in a state where there's global threats everywhere, and we're really focused on preparedness. 6 million units of plasma were used during World War II. And we don't have plasma FDA approved right now, like to be used on, or for dried plasma to be used on burn patients, to be used in the far forward environment. I mean, it's bizarre. I mean, dried plasma is a thing from the past. As
we clearly need to get this done for sure.
Yeah, and it's funny when I started using a lot of plasma for resuscitation at the burn center, and talked with the burn center leadership and said, in the future we could be using dried plasma, and there are some real expeditionary, advantages for our combat casualties of the future in a prolonged care environment that we need dried plasma for. And that's why we need to use plasma. And people were on board. But a lot of people accuse me of saying, oh, you just want to do this because of the military relevance, or you just want to do enteral resuscitation and plasma because of the military relevance. And it's like, no, it's better for our patients. Like, this is better for the patient in front of us. And it has a lot of relevance to the military and, future operating environments where there could be prolonged care scenarios.
So to sort of encapsulate this discussion a little bit, I mean, it sounds like what you're proposing that would really be innovative in burn resuscitation today, in a sense, borrows from the past, but we would do this in the context of a trial that would test something like maybe plasma resuscitation plus enteral, in combination with enteral resuscitation versus standard of care crystalloid. There have been some attempts, so there are some burn centers that do incorporate plasma, usually late in resuscitation, as sort of a rescue therapy. Do you think this trial is feasible? The one I just sort of sketched out a little bit, is there enough equipoise in the field to randomize people, to just crystalloid versus a plasma and enteral resuscitation? Or do people not think that, is there not enough support for using plasma yet to even make such a study feasible? Do you know what I mean?
Yeah. The feasibility would be hard because a lot of burn patients get taken care of by satellite places and then get transferred to the burn center. And if we've learned anything over 20 years, or if I've learned anything, I think everybody else has, maybe I'm just a slow learner, but timing is everything. Life-saving interventions delivered too late are no longer life-saving, but it's not just for trauma. Sepsis management, bleeding control, vascular interventions. Now we've got stroke teams, we've got, all these sepsis teams, all these things that recognize the importance of timing of intervention, and that these life-saving interventions delivered late aren't life-saving. And so, timing of glucose control, timing of everything. Like, just think about all of ICU care. Now we're very focused on these timings of intervention. And giving plasma after somebody's gotten 20 liters of crystalloid, the damage has been done. And so if we did a trial like that, it would be a negative trial. It would not show a difference because you have to give it early. Same thing with blood. There's so many analogies to, pre-hospital transfusion and showing survival. And if you don't look at those, like the vampire study, that if you don't look at those who could have benefited, the population that died, you're not going to really see the benefit of it. But we know this intuitively, that timing matters. So the one trial that I think that was stopped was Propolis, and it was going to be in San Antonio. If any place could get plasma out there and just give plasma for any burn, greater than 20 or 30%, San Antonio, because they already have blood far forward on so many rigs. The Lights Network and Jason Sperry is doing a burn trial. And I've had a chance to, thanks to Jason to being so generous and getting input from people, had a chance to kind of contribute to the study design. And really, it's about timing. And it's hard in any system to get plasma far forward enough and to get people comfortable enough that outlying places that are then going to transfer a burn patient in to use plasma. But we got to use it early. We got to use it early. And we talked about this yesterday. It's anti-inflammatory, right? Mm-hmm. It's anti-inflammatory. And if burn shock is a plasma deficit, and if burn shock makes you pro-inflammatory and super revved up, then we should be giving plasma and something that's anti-inflammatory. And we do the opposite. So we have, really. And People are in the burn community, I think, are getting more like excited about this, but we are really kind of set in this is how we've done it, and these are the formulas we use, and it's probably not the best thing for our patients.
Right. Well, it sounds like we'll have to continue to pursue change in this area and get the right trials done that allow us to definitively answer the question and move potentially towards plasma-based resuscitation. Jen, it's been awesome talking with you today about
thanks,
this.
Thanks, Andre. It was fun.
And hopefully we can continue to advance the field.
Awesome.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.